Welcome to another episode of the Dog Suit. Today we have with us Dr. Vaishal Shah, the newly appointed director of the Sleep Center at the Cleveland Clinic. Originally from India, Dr. Shah earned his MBBS from NHL Municipal Medical College in Gujarat, and following this, he completed a master's in public health at Cleveland State University. He went on to complete his pediatric residency and his sleep medicine fellowship at the Cleveland Clinic, where he has been a faculty member since 2016. Since joining the clinic as staff, Dr. Shah's pragmatic approach and resourcefulness has helped him excel in leadership positions, initially serving as the interim director and now director of the Sleep Center. Outside the hospital, Dr. Shah was a seated table tennis player in India and is an absolute force to reckon with on the pickleball courts here. This is something I can vouch for personally. To begin with, how did you sleep last night, sir?
I did great actually. Usually outside of stressful nights, I'm usually okay. Try to follow my own
Advice.
science. I try to preach, yeah. So,
What's something that all of us can do? A quick 2 minute thing that we can change that would help us sleep better.
so
Pickleball.
for sure. See, so the exercise and activity definitely helps. But here is the thing. I say sleep is the best medicine. Because first of all, everybody needs to sleep. Like find me one person in world who doesn't need to sleep. It's free, right? It doesn't require prior authorization to go to sleep. Otherwise, nowadays, like require prior authorization to do a lot of things. So what could be better, right? A free medicine and so forth. But the key is quantity, quality, and timing, right? So more consistent you are, more in your according to the age you are staying within the range, and making sure the quality is pretty good overall without any kind of medical conditions. That's when you get most out of sleep. And sleep affects a lot of things in life. You will be surprised how much research is out there. So please don't compromise on sleep because in the fast world, that's the first thing we compromise, right?
We will let our residency directors know to let us sleep more.
Yes.
But
Uh,
sleep is such an interesting concept. Everyone speaks about sleep, sleeping well, sleeping timely. But I have heard people always complaining about they have been unable to sleep. Example, even from where I come, like I grew up in Dubai. People have this one common problem: they're not able to sleep. What factors have you actually noticed?
Yeah, so when you can't fall asleep, typically there tends to be one of the three things. Number one, either the sleep hygiene is poor, like we take care of our body, such as we brush, shower, and so forth. There are specific set of steps we recommend for hygiene. So if somebody is not following, it's all over the place. Many times that leads to their brain getting conditioned to not learn to fall asleep in their environment. And it could, outside of that, the two other condition, what we call body clock or circadian rhythm problems, which is very common, particularly the delayed clock in younger ages, the adolescent, all the young adults, and or insomnia, which is trouble falling asleep, despite the fact that you keep enough time and give yourself enough opportunity to sleep. So it could be any one of those. And generally, when we talk to patient, we try to look at it is one or more. And more
hmm,
often than not, I find it to be a puzzle with multiple moving pieces. So there could be more than one reason.
Interesting.
interesting. Right.
Interesting.
So I think Dr. Shah, as we've spoken before, at the Doc Suit, we try to bring guests that look at medicine differently and they look at things beyond medicine as well. And I think you obviously are one of them. We're very, very lucky to have you here. I guess just to kind of start off, we talk about, how the best physician leaders are physicians first and leaders second. What is your opinion on this, especially in the context of healthcare?
Yeah, I think my personal opinion is you need to be content expert first of all. So you
Right.
need to know your area very well. You can't be good at everything, but at least within your own area, having a strong expertise and knowledge does help a lot. Learning the leadership skills and administrative skills can always wait, right? Uh, one of the one of my residency leader who, at the time of graduating, I was trying to ask that individual for an advice
Hmm.
that, hey, should I just remain a clinician? Should I try to go for administration? Should I go for teaching? Should I go for
Yeah.
research? And that advice still resonates with me, that be the best clinician first. Uh, you don't want to claim yourself to be a leader or administration if other people do not see you, and you don't want to do it, and you don't have skill set to do it, or
Got it.
you don't want to develop the skill set to do it. So I think content expertise is number one for me, and then building upon that foundation to develop leadership skills, administrative skills. You don't have to learn every skill. You have to learn a few very good, and then build a team around you who complements your own skill sets to get the job done. So that's how I see it.
That's a very valid and interesting point. I think so it narrows everyone's focus on how excellent clinicians eventually become excellent leaders. The question is also how are they both different compared to like treating OSA versus actually leading a whole entire department like you are doing, and what skills did you really focus on during your whole entire journey?
Mhm. I think they are not necessarily different. They're, I think, two sides of the coin, but they're part of one coin. So both affect each other, right? If I don't know OSA very well, I'm not going to know what kind of systems I need to develop to treat to is a
Right.
systematically, to develop team, to develop processes, to develop operations, to help patients through that standpoint. So I think they're part of one, just with the different skill set and flavors what you need on each side. When I started, first of all, first and most important skill is that you want to be in the leadership role, right? If
Hmm.
you just don't have a, they just don't want to be, don't go
Don't
there.
try it.
That's not,
Right.
don't even try. It has its own perks and perils. It is rewarding to develop something, build something, grow something, help people, but
Right.
it can be daunting at times also. It can weigh you when you have to take big decisions, and some decisions may go right, some decisions may not go right, right?
Right.
The When I was looking into it, my life story situationally was, fortunately, I was given certain leadership roles earlier into the career
Right.
because of certain thinking, and then eventually I said, okay, I need to become better at what I do. So I
Right.
started with what is my principle, first of all, and that was be better tomorrow than today. And that helped the most. And that was the goal that I apply to every aspect, whether it's personally or whether it's to the center, to a program I was leading, and that helped the most. Then I try to understand what are the great leaders do, what makes them great, what are the
Hmm.
skill set they need to learn, right?
Hmm.
I think there are several. If you look and read about leadership out there, you'll find a lot. I think the few which has helped me the most, and I very early started learning, is number one, emotional intelligence. I think that is the key,
Hmm.
number one skill probably any leader should have. Second, problem solving and conflict resolution, and third,
Hmm.
communication. Early into leadership, if you master these three, it goes very, very long way.
Hmm.
How did I do it? A lot of self-learning reading, but I was fortunate to have a great mentorship as well as self-directed and chosen leadership training programs, particularly institution like Cleveland Connect tends to have a lot of great program. Even American Academy of Pediatric had one, which
Right.
kind of really shaped my thinking
Thinking.
and as a leader. And then most important teacher to me is as execution and feedback of those leadership
Mhm.
skills, because you can learn anything in a session, you can read anything, but if you
Right.
don't execute, implement, and don't learn from that and improvise,
Right.
those are all useless. So I think that has been the best teacher over the time in learning the skills and getting better at being leader.
Yeah, I think so. That same thing applies to residency. Like we do see cases every day, but until we actually go home, read a bit, and it becomes very impossible to apply to future cases in the future.
I think I
Uh,
have one before we move on to the next question, just one more question. So
yeah.
you said that being a domain expert is extremely important before diving into leadership. Do you think that's because being a domain expert allows you to see all the variables, and then being a leader allows you to play around with those variables and like solve and like streamline those processes? But if you're not a domain expert, you will never know all the variables that you need to work with. Is that
Yeah.
accurate?
Yeah, somewhat similar to that. It gives you more global perspective rather than one aspect only, like
Right,
administration only. It gives, and it kind of helps you clear up your blind spots, and that's how I see
right.
it. So, like, I'll give you an example that if I did not keep up with, let's say, obstructive sleep apnea, you mentioned a very common condition, right? Within last 10-15 years there are so many treatment options which has come out now.
Right,
If I did not keep up with that, I would not know what to bring to my own center and develop further. Hypoglossal nerve stimulation developed by a company called Inspire is similar, is an example, right?
right.
So the cutting edge technology got FDA approved in 2014-15 timeline, but if I had no idea, how am I going to bring it to my own center as a leader, and so forth. So I think it kind of removes those blind spot and really increases your vision, peripheral vision, quite a bit to see what's going on in the field.
Physician first, leader second, for sure. For sure.
Absolutely.
Got it. Yeah.
So how do we become a better clinician at
So
this?
it's the same concept, right? First of all, the books, the training programs are great. They lay the foundation, but they don't teach everything, right?
Correct.
The communicating with patient.
Right.
Sometimes medical conditions are complex. You may not be able to solve that medical condition because there might be limitation of medicine. But how we make that patient feel, right, is very important. The skills, similar, emotional intelligence, talking to them,
Right.
validating what their concerns are, addressing them, are very important. So while the medical knowledge comes from the training, real training in treating patients starts after, and
Right.
so forth. Yeah, I'll give you an
Right.
example. After practicing it again and again, the first time when I go into the room, instead of assuming, first question I ask, tell me how would you like me to pronounce your name, right? And then
That's
second
a
question
nice
I
one.
ask, tell me first broader, what are the challenges or issues related to sleep do you have today? Once they do it, I summarize and say, out of this, what bothers you the most? Because we think sleep apnea, they think my spouse is bothered, right? So problems are
Mm,
very different in how we think as clinician versus what patient thinks, and so forth. So you want to know what is bothering them, and if you don't improve that part, no matter how much medical knowledge you have, that's when you fail, and so forth. So
Got it.
that's nice.
that's the key to becoming the better clinician. Know where are they coming from, know what are they looking, what are their goals, what are they trying to improve.
Got it. Got
That's
it.
nice.
I think so. Those are very valid communication key takeaways that everyone should obviously implement. And I think so. The issue is also the lack of time, right?
Mhm.
Yeah.
How do you spend the most amount of time with your patients? But going back to the next question, Dr. Shah. So at the Sleep Institute, you obviously, as a leader, you had spotted multiple workflows, right? And how do you really go about spotting the gaps in the workflows? Like, what is your thought process? Even an example would really work because everyone, I've spoken to many people who speak about QIs,
Mhm.
optimizing workflows. But what is your approach to spot gaps and redesign workflows and then implement multiple processes in that whole workflow?
Yeah. So my first successful project is probably a perfect example. So I would say it stemmed out of frustration actually. So in frustration of being a patient and clinician, both sides, not just one.
Yeah.
A while ago, let's say around 2018 or 19 was when I was asked to lead the pediatric sleep program, and I was by myself, and from like everybody else had left. So from that, I had to rebuild the program. But at that time, the biggest problem was whether we are providing great care to the patients, right? That's
Mm,
number one key goal. So I realized that a lot of patients are contacting us because they just can't get in. They just can't even schedule with us, right?
mm,
And on the other hand, we have openings, so there is a mismatch. So first part of this is when there is a mismatch, that light bulb should go up. There's something not
right.
functioning, right?
Right.
After that, I closed my eyes and asked myself, if I'm a patient from point A of a sleep problem to point Z, long-term care, what are these steps looking
Mhm.
like? And that's what we call process, right?
Right.
And then once you come to that place, you try to study objectively where the challenges are. You
Mm.
find good people on your way who will help you collect data, talk to patients, talk to stakeholders, and basically do so. And then you'll identify key issues.
Right.
So in this situation, I was seeing that only we're getting tons of consult orders, right? But only
Right.
40 to 60% were getting scheduled.
Right.
So big, big,
Mm-hmm.
big hurdle in the growth. If I just remove that hurdle, it's gonna get better. So once I studied, I realized the scheduling system is all over the place. There are so
Right.
many different ways patients are scheduling. In the processes, there are 5 or 6 completely broken. So we picked a few and studied which are the most impactful ones, and it
Right.
seemed that patients needing to call was
Mm.
the biggest problem because they spend half an hour. Somebody on the other end spend half an hour who does not know what your clinic template and schedule and who you are. They're
Right.
trying to make decision and schedule. So then at that time I was reading the Amazon Unbound book, and there is a concept about time they describe and say, if you really want to provide good customer service, you want to reduce the friction and make it very easy for
Right.
customers to assess your services. And that's how the Prime's basic foundation is, that one click thing you get, can buy something and comes to your home, pain
Right.
free, easy. So I was
Right.
like, why can't we do this for our patients? What's stopping us from doing in a large institute like Cleveland Clinic? Ultimately, brought a team on board, and we developed on a patient portal called MyChart, a very simple process where any clinician puts this pediatric sleep console. There is a simple pop-up comes in a MyChart. Patient has to call nobody. They can directly click on that and schedule with anybody. Fast forward 4 years later, from that 40 to 60% scheduling, we went about 90% and maintained it over 4 or 5 years. Now the problem reverse happened. We had so many patients that we didn't have enough provider. Then because of that, it went below 90% because we just couldn't fulfill more patients.
That's a
But
good
that's a
problem to
bad,
have.
yeah, that's a good
It's a good
problem to
problem to
have compared to, yeah,
have.
compared to patients being frustrated, right? So so the point is, in if you think from workflow or operation standpoint, as
Yeah.
simple as these are the processes. Once you figure out from A to Z what are the points and study them and try to work on highest impact ones, that's where magic happens. At Cleveland Connect, there is something called continuous improvement, which is it's a concept which is quite powerful
Mhm.
in helping this. It's not always present everywhere. It's kind of a little bit misunderstood between quality improvement and continuous improvement. I see
Mhm.
quality improvement as a sub part of continuous improvement. So
Mhm.
continuous improvement is this a structured methodology to study anything, whether clinical care delivery, education, and apply systematically solutions
Right.
to improve anything. And after I did this first project, then I realized the world of continuous improvement, learned a lot of skills, build skills for the teams, and that is what has then improved workflows, operations, other things at Sleep
So,
Center.
so it's more a framework then. Like continuous improvement is more a framework to approach any discordance or any problem, and then like go in, break things down, and then solve for them. Right.
Yeah, absolutely. It's framework plus tools.
Plus tools.
So it's framework, data analytics, problem solving
Mm-hmm.
tools. There are tools like A3 Charter, bigger projects,
Right.
Kaizen cards, or just what we call just do it, smaller problem, just implement something, right?
Right.
So there are a number of tools available in there, and it's well designed here, at least at Kernel.
Got it. Got
Yeah.
it. Yeah, this is the problem which you identified was more from a data point perspective, right? But there's some patient frustrations that you might identified. How do
Yeah.
you go about that? Is it through your clinical expertise when you're treating, and then you anecdotally maybe make a hypothesis that this is a problem, and then you go reverse flow backwards?
Yeah, generally, your first point is patients will tell you that we
Right.
couldn't access you. They're gonna basically be like, our experience was not that great. That's when you take things very seriously,
Hmm.
and so forth. And when it becomes again and again in pattern that multiple patients are saying, that there is a serious issue. And then in clinic, it takes just 1 or 2 minutes more, even though it's not clinical issue, to ask them, okay, tell me what happened and what's your experience. And you started realizing where the issues are. Then you go backwards and then go from point A to Z, and putting into perspective. I even have involved patients in developing these processes. So
I see.
they are the most important part of the team,
Right.
and so forth. So,
But so I think to that point, I think there's also something called like a my chart survey, right? Like at the end, patients will get like a survey, and this isn't just the sleep center. This is across. I feel like I've seen it across multiple specialties. That the patient gets like a survey, you fill it up, and then it's tracked to the provider as well. So if the
mhm,
same person is getting multiple complaints or the same person is getting like that, that's trackable. Essentially, that is a metric that can be tracked
mhm.
by leadership, right? And so I would imagine that's another other way of getting identifying common issues and common problems.
Yeah,
Um,
there are several we get back.
yeah,
HCAP, CGHCAP is one of
right. That's
the.
another one, right?
So from that you learn subjectively, but and so what you said, Dr. Javeri, is about that, and that's a
Right,
huge eye opener. There's also objectivity. So if you are seeing, for example, sleep apnea, right? At the center, if you have a mass population data showing adherence is not that great, then you know there's a problem. So
right.
there's objective way of identifying that there is something not right, and so forth. So both, if you combine, mostly you'll get a good vision of what is happening.
Got it.
Right. So, I think moving on to the next question. So as we discussed in the introduction, you were the interim director of the Sleep Institute last year, and then now you're a full director at at the Sleep Center. Um, can you tell us what part of that job surprised you the most when you
Yeah.
first took on that responsibility?
I think more than first, as it went further into the role, that's when
Yeah,
the biggest surprise was how far you can go, how far you can push yourself, how far you can push the limits, right? Every time I reached a limit and thought that would be my limit, then there
right,
was another limit came that it expanded that horizon. So that was always surprising to me, that, oh, we could accomplish this also, we could go this far also. So that was first. And second was the sheer amount of knowledge, and skill sets out there. It's a sea. It feels that I have to learn everything, I have to be best, and I can be best only if I do everything, and so forth, right? So it's all this mixed emotions about how many things I can take in
right.
while trying to handle that ship on a day-to-day basis. Uh,
And this is coming from somebody who has done his pediatrics residency and fellowship at Cleveland Clinic. So that's just like putting it out there.
yeah, so I mean, it's yeah. So that was the surprise, that how much you know and don't know, right?
Right,
We sometimes will feel like, do I know, don't know, but that's not the case. You are here because you know a lot. Somebody else saw that you know something strongly,
right,
but then there's also a whole sea out there of what you don't know. So
right,
I think that was surprising, but like rewarding aspects. Once you learn something new and make yourself better and implement every day, that's what drives me,
right.
and so forth. And that's the fun part of this.
Yeah, I think so. The most important thing as a human is to be very humble and just
Yeah.
assume that we don't know everything. And
Right.
that's when true learning really starts. That's what I have believed, or that's what my first year residency really taught me
I
in
think
general.
even just not even just a residency, of course, that's taught us a lot, but just like being on this podcast and like inviting people and interviewing people, every time we think we've come across somebody who's like opened our eyes, the next guest comes on and completely blows our mind.
Yeah,
And we never see the same thing, and we
Mm.
never see medicine in the same way, in the same dimension again.
yeah,
Um, so this podcast has been very fun and interesting, but it has been also incredibly humbling. I will say
definitely. I totally agree.
that.
Yeah, that's the beauty of human nature and brain, right? That
Yeah,
we all
it's,
think differently. There is
yeah,
no such thing as perfection. I call perfection as a perception.
Right. That's
of what
nice.
you call perfect. Like, and a lot of time, like when somebody gets like, okay, I need to do this perfectly. I'm like, okay, what is it perfect in your mind? What is it
Right.
that? And if you ask same thing to five different people in the same
Be
room, they'll
different.
give the same different answer, right?
Different
So
answers. Right.
yeah, so
Yeah.
Yeah. Dr. Shah, I had a follow-up question to it's related to leadership itself. You also lead an academic program. And what are the building blocks that are really required in an academic program like the one which you actually lead?
So, I mean, one of the things I like about Cleveland Clinic is what we call tripartite mission. And those are what I call building blocks, right? And I call not only tri, but fourth part of that. Tripartite being clinical, education, research, and fourth being the administration and business of medicine,
Right.
right? The key here is to find the balance. If you are imbalanced in one, uh, it's gonna fall through the cracks and so forth. So and that is the hardest leadership challenge nearly everyone has within US, probably healthcare and as well as outside also. But how
Right.
do you find that balance? Or you have to gauge what is my balance, right? Do I have good clinicians? We are doing very well on the clinical side. What am I struggling? Is it like education struggling? Is it like research struggling?
Mm.
And keep on working and shifting your focus
Mm.
uh, on maintaining what is working well, but then those other blocks enhancing and building them up, while keeping and making sure the administration and business side is sound, uh, and not just taking over. And more so, as I said, I see them as a part of the coin of just two sides. So that's how I see it.
Got it.
I would imagine that the administration and the business side is what allows or what provides you the resources to run the education, the research, and the clinical side as well. I'm sure the clinical side also provides resources to the institute and to the sleep center. But specifically for education and research, I would imagine you need to have like your fundamentals very strong, your business fundamentals very strong, right? And as physicians, I don't think any of us take courses for like running businesses. How when you get that job and you get that opportunity and you're like, okay, from today I'm going to be running all of this. How does one go about that? That seems
Yeah.
intimidating to me.
Yeah, I mean it as I was speaking with somebody, I'm like financial literacy is something lacking in even the high schools and schools, right? It
Right.
should start at that time. Basics
Yeah.
of finances. So the from early childhood all the way to college, it, I lived in a household of a mother being businesswoman and a father being physician. So you can
Love
imagine
it.
the
That is,
thought coming together, right? So both
yeah,
sides were constantly discussed, and at some time look like okay they are
nice.
part of same, and sometimes look like they're just polar opposite. And you're like,
Right,
okay, so how do you bring all this together?
right,
So being in that environment from after the residency, once things got settled, I personally took interest in my own personal finances. I still do budget every home budget every month or quarterly or so forth to try to know what is
what's
going on.
going on?
Learning just that basic uh, really helped later on because it's just a massive size of what I did at home, right?
The fundamentals are the same.
Fundamentals are the same, yeah.
Right,
So it's just more sophisticated and complicated, but you also have team members who have sophisticated knowledge and tools to help you there.
right,
Once you get to leadership role, fortunately, even though there's like no manual to this, right? At least we are I'm at an institution which does want its leaders to succeed. So they provide training. Actually, they
that's right,
help you learn number of things: how the finances work, how the business aspects work, how the operations work, what are the factors affecting. In fact, in some of the leadership courses, we had an entire day of mock to run an hospital as a team, not as a physician, as an
right,
administrative. And then you have
Got it.
team members, right? So you have administrative team members. Many of them are really good
right,
at knowing there are financial members, there are operational members, and you can always rely on them, develop a trustworthy relationship with them. And as you mentioned, Mohit, the learning is ongoing. So you don't have to beat yourself as self as that. Okay, now I'm a leader. I have to know this today.
right,
The key is patiently keep
Continue
on
learning.
going. Right. You keep on learning through various sources and understand what is happening over time.
I understand that. Yeah, that's a very tough thing to do. Overall, I feel as a human itself requires a lot of discipline, and that's very important, more than motivation, I would say.
Yeah.
Discipline, as well as one thing I'll say, is that want, right?
You
Not
would, yeah.
That
many
hunger.
many physicians would say, I love to treat patient, I love to make their life better, and then go home and be peaceful, and that's completely okay. If
Right.
you like that, be that way. But if you're going to be in leadership, you probably want to have that want, that I want to learn, because without learning that business aspect, it's going to be hard to succeed that way.
Right.
Yeah, yeah.
I feel
Uh,
that's such a good corollary. I feel like that also applies to academic medicine. Like there are a lot of physicians who want to treat patients and go home, and that's fine. And then there are people who are like, oh, I want to contribute to this field and I want to do research and I will make sacrifices for that, but I will, I want to do it. And it's impossible to continue or sustain any either of those, the leadership path or the research path, without having to actually want it.
Mhm.
Um,
yeah, totally agree. And
and
Dr. Shah had a very, I would say, im- very interesting question from a more clinical standpoint. So, this I also got an insight from my clinical practice during residency. So, on an average, around 30 million Americans really have OSA in general. Fraction of them are really diagnosed.
Mhm.
And even those people, many of them are really non-compliant to their masks, which is the standard treatment of CPAP. I mean,
Mhm.
which is a standard treatment of OSA. What is your intake to that, and how do you see these things changing? Why this has always been a problem?
Mhm. Yeah, so generally I use word non-adherent more than compliant. Compliant sounds like we are in law and we have to comply. The reason I say non-adherence, because many times reasons are quite widely variable.
right,
The Unfortunately, with sleep apnea, the way the pathophysiology is, there is no perfect treatment, no
right,
one perfect treatment.
mm,
And again, there is no specific cure unless it's related to elevated weight. And then if you're able to lose to an extent where number of patients could succeed with that and
right,
then have cure of sleep apnea.
right,
The the past, if you go 10, 15, 20 years, sleep medicine is a relatively newer field, right? The only
right,
CPAP was the treatment, but that's no
right,
longer the case. There are a number of other treatments have emerged, which either as a solo treatment, or more often what I tell patients as a multimodal treatment, more precisely tailored towards their issues, can have role in helping them succeed.
right,
So the CPAP is not something natural inherent to our body. It's something from outside, a sensory device, right? That you have to wear and learn or get desensitized to it.
right,
Yeah, yeah,
Um, Ranging from as simple as dry mouth to all the way too much pressure to as simple as I just don't like it or uncomfortable. There are quite variety of
right,
reasons why we see non-adherence.
right,
Many what I tell my patients in, and depending on the literature you look at, the non-adherence could be 30% to 60% of patients, right? And so forth. So I tell patients that, look, first of all, uh, don't give up too fast, because many of the simpler problems within first few months we can help you, and the new
mm,
technology is evolved and every day it's evolving, and can to help the patients.
right,
The mask used to be this big. Now some of them, patients who don't breathe through mouth, have miniaturized one, pretty much very simple cushion pillow, right, to improve their comfort, minimal footprints and so forth. So
right,
CPAP technology itself has gone leaps and bounds.
mm,
Uh, so we follow up with them closely. We try to help them if they're still non-adherent. At that point, if we have done everything, patient has done everything, then we talk to them about alternate treatments out there. So oral appliance or mouth guard are very well scientifically studied in mild cases. Hypoglossal nerve stimulation is nowadays implant-based treatment in select candidates,
right,
in moderate to severe cases. Various surgeries have wide variety of different level of success, although lesser than the other treatment I mentioned. And interestingly, very recently, one of the first medications originally designed for weight loss called tirzepatide got approved for sleep
right.
apnea treatment as of
That,
December.
That's
2024.
the golden boy of pharmacology
It's
today.
like a miracle medication.
I swear,
Yeah.
like she'll be on
So
agonist for everywhere. Sorry,
it
go
is
ahead.
seen that way. It is going to have pros and cons, right? But the
Yeah,
point being is compared to 10 years, there's a quite paradigm shift in how we
yeah,
treat sleep apnea.
yeah.
There is a lot available out there. Don't give up on for CPAP, and then if it is hard to keep it, don't give up on treating sleep apnea,
Right,
because it's no longer that you can't get help and so forth. And that's the main message I'll probably give to everybody.
right,
Wow.
right. Um,
I
how
had a
about yeah? Go ahead.
Go
Sorry.
ahead. Yeah. So, sleep is a very common issue. I mean, in the past, let's say, 15 years since we everyone has an iPhone, there was a rise in digital interventions, but
Mhm.
many of them I feel have failed in actually addressing sleep as an issue. What are your thoughts on that?
Specifically related to a device use or electronic use, or
Digital apps, digital interventions.
You know,
Uh,
things like mindfulness or something. There are
yeah.
like so many apps that like teach you how to sleep better. Like, do they? I think what Mohit is asking is, do they work
yeah.
or like?
Yeah, so actually, we recently are trying to adopt. We had our own cognitive behavioral therapy app at Cleveland Clinic for insomnia patients.
Mhm.
But in general, there are few fold. Number of these apps do a reasonably good job on teaching you sleep hygiene,
Okay,
right? And that is most important for individuals who do not have a lot of sleep pathology. Those are important for individuals who have sleep pathology, but more so for who do not have it.
right.
If you simply follow them, and most importantly follow them and adhere to them, it's going to help and work, right?
Mhm.
The second is, what is your expectation, what are you looking as an endpoint? Many times
Right,
patients are unclear. Okay, I'm tired, and they connect the dot and say, oh, I'm not sleeping well, that's when I'm at. That's one reason, but it's
Mhm.
not always the reason that okay, I want to feel 100% energetic. Sleep might be only causing 50% of that, right? So
Right,
if you use
Mhm.
it and then you feel like, okay, I only improve 50%, it may feel you that this intervention or app didn't work, but that's not the case.
right.
So that's second. And then third, there are more and more interventions coming due to limitations of number of healthcare providers to serve the large population where the technology is being utilized,
Interesting.
including AI-based therapies, as a mediator in between before you see sleep providers or particularly psychologists or other aspects which are in high demand and so on. So as we go further and study this more and understand in a proper robust research manner, I think it is going to get better over time, and it has a lot of role in the future of medicine, because we just don't have enough medical provider to take care of everyone's sleep needs and so on.
This is a perfect interlude for our next question, which was like we wanted to ask you about how sleep medicine is viewed globally, specifically in India. And I think what you just brought up, which is um, a dearth of providers. I think like we know that India is producing a lot of doctors, but they're never going to be enough because of the population, right?
Yep.
And we want to be able to address like how do we go about doing that? And I think you brought up digital health. Can you tell us a little bit more about where sleep medicine is in India right now?
Mhm.
And where is it going based on the discussion we've had?
Yeah, so if I provide comparison to the where United States and
Right,
is today, so it's about 30 to 50-year old kind of field of medicine where it started gaining more traction, and it's quite
right,
extensively developed in the US. I think India is probably um, early to mid into understanding at a
right,
level of providers.
right,
There are more patients who are also gaining awareness.
right,
Those are still in more clusters, tend to be at larger
right,
medical centers rather than right outside in the community in penetrating in all parts of smallest parts of India. There
right.
are actually two great associations now. India has ISDA and the ISR, Indian Sleep Research Society, and the other association who has started uh, lab accreditation, training programs, even
Lovely.
certification
It's amazing.
for
Okay.
right. Uh-huh. So there are more and more coming up, but I still think it's in probably toddler phase, infantile to toddler phase compared to a mature
Right.
phase which United States is experiencing. There's a lot to be done about that, and it starts with probably creating awareness in both
Right.
sides, in patients as well as non-sleep providers, right?
Right.
That's where the biggest hurdles are, besides everything else. But that's the first step, probably.
But I think, and you can disagree with me on this, but I think India in general is so quick at adapting, like especially digital interventions, the scale and the speed at which India has done that, especially if you look at like the food delivery apps and you look at, so everything is online, everything is, on the phone. It's so convenient.
Mhm.
I feel like if sophisticated solutions are designed for sleep, and not just for sleep, for other healthcare problems also, and they can be deployed
Mhm.
uh, at scale, I think India might be a toddler right now, but I think it will jump
Mhm.
really quickly, and the with the momentum that like maybe in 20 years we might probably see something completely different simply because of how quickly the adoption has happened.
Hmm.
Right? So like look at how digital payments, how quickly, like
Mhm.
we didn't have PayPal in India, and then
Mhm.
2016 onwards, and now like we have with UPI and everything, it's just
Very advanced system.
it's exactly, it's so amazing, right? And so like that's how I feel like that's what's going to happen in healthcare as well in the next 10 years, where somebody will find a way of developing like solutions.
Mhm.
And like you said, maybe it's not directed towards a population that has a pathology in sleep,
Mhm.
but people without a pathology and still having problems in sleep, like that section of the market, I think would be very easily addressed through digital solutions. What do you say?
That's hmm. Adding to your point, Sharan, also I feel every economy, let's say India or US, let's compare those. Every economy has a hockey stick approach, right? The first stage of that hockey curve is awareness. Many companies are not willing to spend that much
That's
on
true.
awareness
That's
specifically.
true. That's true.
Now, coming back to India, we are still at the very nascent curve phase. Who's going to spend that much money on awareness? What are your thoughts on this, Dr. Sharan? What are your thoughts on this, Sharan? Like, even if they have to be a first mover advantage, like let's say a new
You need
company
to you
coming
need to
up.
let people know that there is a problem before providing a solution.
Yeah, the right consumer awareness, it's very difficult to create. I don't
Yeah.
know.
I think the first digitalization, India is very leaps and bounds moving forward. So as Sharan, you identified, the generation coming up is going to
Yeah.
be pioneer in basically quickly adopting it, right? And so
Right.
forth.
Right.
And
Absolutely.
probably that will help the generation above and below both. Below, I
Right.
think even going to be more advanced.
Right.
The and that's going to help to
Right.
penetrate a lot of this because there are a lot of not a lot of boundaries left when it comes to medicine across the world, right?
Right.
It's the national boundaries and so forth. The information is available so handy on
Right.
internet. PubMed you can access from India and download everything, right? So
Right.
which wasn't the case several years ago.
Right.
The awareness I think will require more than money, more time. Time commitment on someone's part that I want to do it. That's number one.
Hmm.
And second, will require connecting dots in population that what I'm experiencing is due to sleep issue, right? I think that
Yeah,
dot is where the
Ah.
problem is.
got it.
The connection, you might be tired. Like I used to joke when I started that when in India a few years ago, if you're snoring, you're sleeping too soundly and you're too rich. That's why you're sleeping sound and that's why you're snoring, right?
That's the general assumption of many Indians,
You might
including
still see it. You might still see it. You might still hear it, right? Like
Right.
yeah.
in the language we speak, "Goda vechine honge che," that is
Right.
basically means you. So the point is, but that connecting that this is an issue, right?
Right.
As small as it's an issue in relationship,
Right.
somebody next to you,
Right.
right? People accept it and think this is the norm where they don't know
Yeah.
that they can get better. There could be an issue. Once that kind of
Kicks
realizes
in.
that a patient's, it comes to that understanding that this is a problem, it's affecting me, affecting my family, and I need to take an action. it will become much easier. And in order to do so, it's going to be time, not only on medical provider part, but at least a few people who are affected by this as a patient and spending time to spread the knowledge.
Right,
Hmm.
because I think like back to what Dr. Viren Shetty told us about healthcare, that healthcare still functions as sick care and not healthcare, right?
Acute
So
care.
like
Mhm.
it's all
Correct.
acute care, right? So like the problem is like, if you're snoring, you're not actively dying from snoring. So it's not technically a health issue when you think about it.
Mhm.
Like when most people think about it, they don't think about it as a health issue. Whereas if you're having chest pain and are having an active heart attack, that
Mhm.
is something that needs to be addressed right away. Or if you have
Mhm.
cancer, that needs to be addressed right away.
Mhm.
And so seeing, as you said, I think I see your point, like connecting those dots and getting people aware that yes, this is a medical issue and it needs to and can be solved.
Yep. Yeah,
Um,
when I teach fellows, I ask them what is the most important reason we treat sleep apnea. And I don't know if I
yeah.
ask you, Dr. Javeri, this question. What do you think is the most important reason?
We treat sleep apnea.
Why would we
Uh,
treat it? Or why would we treat
uh,
snoring or sleep apnea?
Not just, I would say like I don't know, like downstream medical complications, like preventing downstream medical complications. Is that what
So
most
that's
people think?
okay. So this is a good doctor thinking. Dr. Mirchandani, what do you think? Why do we treat the sleep apnea?
Quality of life.
And in what sense?
Improved alertness, improved concentration, improved. Maybe some people are just off mood and they might just have OSA.
Allow the
Okay.
Probably the
spouse to sleep better. Come
There
on.
you go.
spouse.
So both of you are great doctors. I say we treat sleep apnea to save relationships, right? That's the most important part.
Oh.
So you may have cancer and heart condition kill you, but this is gonna kill your relationship if you don't treat it, right?
So,
That's
so my dad always used to say,
Oh my God.
I want to snore and sleep. Now he's only snoring. I'm like, Papa, this is sleep apnea. Go get treated.
so
Yeah.
many times patient comes to us and say, I don't have problem, but my spouse
My
is
wife
hearing.
does,
I'm
yeah.
like, okay, do you want to continue to have that relationship? Then we're gonna treat it, right? So the point is that's I think the most important
I,
part is social
let's
aspect
see.
of this, which is quite under
It's not talked
estimated
about
and
it. Yeah, it's not
correct.
talked about.
Yes,
It's not
and
talked about.
that's not the not insurances recognize that as a
Yeah.
reason for treating, nor many times we recognize as a physician, right? But that's what they're bothered by. So
Hmm.
I think once that
Interesting.
awareness comes that I really want to make my and my family's life better, that's when it's going to change.
It comes to, I see.
What should be the ideal strategy to make awareness at scale? That's a very important aspect to consider.
I think if you have to make awareness, first I would ask every spouse that what's happening to their whether the spouse is snoring or not, and whether they're bothered or not. And I can tell you that that's gonna start the conversation in the family that
Uh,
we got to do something. Because patient is sleeping, they or a person is sleeping, they have no clue what's happening, right? And they're
hmm.
snoring, and they're like, okay, I don't know. So I think that's where we should start. Like,
We,
if you have to do a media campaign, say, how many of your partners bothering you can't sleep because they snore, right?
yeah, our viewers are gonna write to us that you're breaking up our relationship. Stop posting.
Wonderful.
No, but I think this was amazing. I think we can continue on and on, but with respect to our time, I think this would be a nice way to end. Thank you so much, Dr. Shah, for coming on our podcast. We really enjoyed this conversation. Like again, Mohit and I learned 50 new things today, which we will continue to learn every day. Um, I think that's all from our end. Thank you for joining.
Yeah, thank you so much.